Fei, it feels really nice to be back and recording podcasts again after parental leave, but even 6 weeks later, I feel like I have missed a whole world of things in OBGYN.
Yeah, me too, especially 9 weeks out. But thankfully for us, we can refresh our memory with the OBG project.
That's right. The OBG project kind of has their great summaries in these bullet point formats online. They've got resident exclusive resources, the core curriculum, and they've got a new project in the primary care med project. You can check that out as well, which lets you get up to date with all those primary care guidelines that we got to keep up with too.
And even better, if you're a resident, remember that you can get OBG first absolutely free. So if you want to figure out how to do that, go ahead and go onto our website, click on the sidebar, and link to the OBG project. All right, guys, welcome back. This is Faye.
This is Nick.
And this is
Creogs over coffee.
And today we have with us a very special guest. We have with us Dr. Molly Kornfield. Dr. Kornfield is a third-year fellow in reproductive endocrinology at Oregon Health and Science University. Welcome, Dr. Kornfield.
Thanks so much for having me today.
We are so excited to have you, particularly because I think the last time that I thought about hyperprolactinemia in I'm going to work it up sense was forever ago. I mean, my patients are usually replete with prolactin these days. But what are our learning objectives for today, Dr. Kornfield?
Thanks. So the learning objective today, so by the end of this episode, I want the learners to be able to explain when do we order a prolactin level, how to interpret an elevated prolactin in the context of the patient's history, and to develop a differential for potential causes for that elevated prolactin, including possible causes of a false positive value. I want the learners to be able to describe the next steps in the setting of an elevated prolactin, including ordering and interpreting the appropriate imaging, and to discuss the management of hyperprolactinemia due to a prolactinoma, including medications, appropriate follow-up, and that's in the context of desired fertility as well as in pregnancy.
Well, great. I'm eager to learn as well. And like Nick said, I really haven't had to work up hyperprolactinemia in any sense in the most recent few years. So I guess, let's start with your first objective, which is, when should I order a prolactin level?
So you're going to be ordering your prolactin levels as part of your routine workup for primary or secondary amenorrhea, oligomenorrhea. You actually will order prolactin during a workup for recurrent pregnancy loss, which is often missed, as well as a patient with infertility and a patient with galactorrhea, or leaking of liquid or milk from the nipples. And whenever you do a history for any of these conditions, you really want to make sure you ask about galactorrhea, but you don't need that galactorrhea symptom or sign to order a prolactin. So actually only 1/3 of patients with hyperprolactinemia will present with galactorrhea.
Got it. And I feel like I've heard that prolactin is kind of sensitive to other things in the environment, and that there's like a potential for false readings, if you will. I guess my question is, a lot of these patients just come to you in the office and it's like, hey, I'm having irregular periods, or hey, I'm not getting pregnant. But are there special instructions? Do I need to bring the patient back before ordering a prolactin level?
Yeah, definitely. So there can be a lot of causes that can lead to a falsely elevated prolactin level. Ideally, you draw your prolactin fasting first thing in the morning, and after a few days, I usually say 3 days with no nipple stimulation and no exercise, or really vigorous exercise. But I think it's totally reasonable to just get it with your initial labs at that first visit when you're meeting them. And then if it is elevated, then you can repeat it with these conditions as well. Since most patients, it'll be normal.
All right. So let's say you go ahead and you get that prolactin level. What exactly is considered an elevated prolactin? And then, what do I do with that?
Yeah, so reference ranges will probably vary by your lab. and some use greater than 20 nanograms per milliliter. Our lab has switched to using greater than 26 nanograms per milliliter in female patients, which would be considered abnormal, whereas less than 26 would be considered normal. If you have a mildly elevated prolactin level, like 26 to 40, it's totally reasonable to just repeat it first with those conditions we talked about: fasting, no nipple stim, no vigorous exercise for 3 days. And pregnancy can also cause elevated prolactin, so hopefully you've ruled that out with your initial workup for oligomenorrhea, but make sure you get an HCG if you have not. And then you'll want to look really closely at your patient's medication list. So many medications can lead to elevated prolactin. You can find a very extensive list on UpToDate. And a lot of these meds are antipsychotics and antidepressants. So two really commonly prescribed medications that lead to very high prolactin levels are risperidone or metoclopramide. If they're taking a medication that you can safely stop that is known to cause hyperprolactinemia, then you can try holding it for 3 days in the setting of that elevated prolactin and then redraw. But a lot of your antipsychotics you're not going to be able to safely stop, or you're really going to want to talk to their whoever's managing that, their psychiatrist, about that first. Renal disease can also cause elevated prolactin, so make sure you know that history. And then you're going to want to make sure you've got a thyroid panel as well. Hopefully you've gotten that as part of your initial workup for all of these conditions, since all of them indicate a thyroid workup, a thyroid stimulating hormone. But really uncontrolled hypothyroidism with a very high TSH level can lead to elevated prolactin levels, because the thyrotropin releasing hormone that's coming from the hypothalamus, remember from your endocrine block in first year of medical school, it stimulates not only TSH production, but also can stimulate prolactin secretion in the pituitary. And this can actually lead to pituitary hyperplasia and overgrowth of the lactotrophs over time. So if that's the cause and that's the case, you really want to treat thyroid first, then reassess what's going on with the prolactin, since that could be a cause of your elevated prolactin. We also should talk about macroprolactinemia, and this is just kind of an interesting side issue that can cause a falsely elevated prolactin. So most circulating prolactin, about 85%, is monomeric, but there are some polymeric forms that are actually called big prolactin and big prolactin, and that's not a joke. That's actually what they're called. And the big and big prolactin are actually less active. They're less likely to cause problems, but they can cause a falsely elevated prolactin level. So if someone has really elevated prolactin and has absolutely no symptoms of hyperprolactinemia, it might have even been found incidentally, you may want to suspect macroprolactinemia and rule that out. So your lab isn't automatically testing for macroprolactinemia. You'll want to go on a deep dive and get this really special test that uses polyethylene glycol to try and rule that out. That's kind of a side issue, but just something that make sure you've heard of that.
That's really fascinating. I've never heard of that before. And so I've got to say, you've moved us through some laboratory things. We've talked about this super fascinating macroprolactinemia. Do we need to hit the big button too at the same time and order a brain MRI? I know that's part of the workup.
Yes, I would say after you've excluded pregnancy as a cause, of course, and excluded a medication interference, and have really this persistently abnormal prolactin level, you should definitely obtain a brain MRI. And the prevalence of a pituitary lesion is actually in 50 to 60% of patients with an elevated prolactin. So it's pretty high yield to get that brain MRI. And make sure that you're noting to the radiologist that you're evaluating the pituitary. So instead of just typing brain MRI, you might need to type in pituitary MRI or add a extra note, because they're going to take extra thin slices through the pituitary to be able to evaluate that really well. In most cases, you're looking for a prolactinoma, which is a tumor of the prolactin-secreting lactotrophs in the pituitary. However, other tumors or cysts in the pituitary can also lead to elevated prolactin levels. And if a patient has a pituitary tumor, remember back to your, head and brain anatomy from first year as well, the pituitary sits right under the optic chiasm. So you're really going to get visual field testing for your patient, and also ask them about headaches and vision changes that could be occurring. And on the MRI, sometimes you can tell if it's pushing into or affecting the optic chiasm. In addition to prolactinomas, other abnormal findings in the brain can also cause hyperprolactinemia. So this predominantly can occur through disruption of the hypothalamic pituitary stalk, because remember, the hypothalamus secretes dopamine through the stalk to inhibit prolactin secretion. So usually dopamine is turning prolactin off. So any disruption of that stalk blocking that dopamine could then also lead to hyperprolactinemia.
All right. So that's a great overview of kind of how to work up elevated prolactin. So let's talk about, this hypothetical patient who's coming to us. They have irregular periods, but they want to get pregnant. And now, they have hyperprolactinemia. You got the brain MRI and they have a prolactinoma. So now what do we do?
So at this point, if you're a general OBGYN, you're probably going to want to co-manage this patient with an REI like myself and or a medical endocrinologist. And just some definitions, and I was actually quizzed on this as a resident by an MFM, but some definitions to know: a microprolactinoma is less than 1 centimeter in size, and a macroprolactinoma is greater than or equal to 1 centimeter in size. And these definitions are important. You want to know what kind of prolactinoma you're dealing with. I'll come back to that. So hyperprolactinemia can be treated medically in patients who desire pregnancy with dopamine agonists, which are commonly cabergoline or bromocriptine are the two that we use. Dopamine agonists, as we talked about how dopamine suppresses prolactin secretion. So dopamine agonist shrinks the prolactinoma, and then your goal is to normalize your prolactin level and restore menstrual function, ovulation, and then hopefully fertility. Although there are some more studies on bromocriptine safety in pregnancy, cabergoline actually has a lot fewer side effects and is a little bit more effective at shrinking those prolactinomas. So that has become our first line. Once you've started cabergoline or bromocriptine, we usually then repeat labs in about a month and then titrate the dose as necessary to get control. If there's a microprolactinoma, so less than 1 centimeter, we often repeat an MRI in 1 year just to assess for growth, make sure it's not growing despite this medication, and often we'd like to see it shrinking. If it's larger, if it's your macroprolactinoma, remember, 1 centimeter or greater, we would repeat it sooner, so closer to 3 to 6 months to repeat our imaging. It's also really important that for patients who have a pituitary lesion, we're still following progression of symptoms or development of any new symptoms despite treatment, including visual changes, headaches, new or worsening galactorrhea, as signs that these conditions might be worsening. And for some patients, medication will not be the appropriate management, and they may need to be referred for transsphenoidal surgery to remove the prolactinoma, and that's usually done by neurosurgery. In some patients who are pursuing fertility, even after starting your dopamine agonists, they may need an additional medication for ovulation induction like clomiphene or even gonadotropin injections or IVF. And this may also be the case if patients can't come off medications that are causing hyperprolactinemia, like antipsychotics, that they've really been stable on that. And so you'll be co-managing that with their provider, managing those medications, as well as a fertility specialist. And in some cases, if a prolactinoma is very, very small and the patient is not trying to conceive, it actually may be acceptable to try and treat their symptoms with birth control pills, which can actually help manage galactorrhea to some degree and help suppress the prolactin. So that's an alternative for a small subset of patients.
No, really excellent overview of kind of the patient seeking fertility or not seeking fertility. What about though if we have a patient, let's say, with a prolactinoma, she was not interested in birth control pills, so she gets started on cabergoline, and now she's pregnant. Obviously, like this becomes something a more interesting sphere and is like an REI-MFM crosstalk. But what do you do in that instance? Is the cabergoline okay to continue, or what do we need to consider if we're trying to make a shared decision, if you will?
Yep. So for your patient who's conceived with the addition of cabergoline, yay, you've treated their hyperprolactinemia, they ovulated, that's great. In the majority of cases, we are going to stop cabergoline once they've had a positive pregnancy test. It's okay to have high prolactin once you're pregnant, and there's limited data, it's probably safe, but limited data on safety of cabergoline through the first trimester. In the case of very large tumors, you may actually choose to continue the cabergoline just because you're weighing kind of the risks versus benefits of that tumor growing, causing visual issues. We don't usually continue to trend prolactin once a patient is pregnant because we know it's just going to be really elevated from the pregnancy itself. And then this is where that differentiating between microadenoma and macroadenoma becomes important in terms of their risks once they're pregnant. So for microadenomas, less than 5% grow in pregnancy. So most of these patients do pretty well. But for macroadenomas are high risk for growing in pregnancy. Actually, 31% will grow. So during pregnancy, you're going to be wanting to really closely follow these patients at every visit, asking about headaches, visual changes, and if any of those develop, you're going to get visual field testing and you're going to get a pituitary MRI. Remember, they're pregnant, so no gadolinium, pituitary MRI without gadolinium, and you want to do that pretty urgently to catch if this is starting to grow. Enlarging and symptomatic prolactinomas during pregnancy may warrant either restarting that dopamine agonist therapy, the cabergoline or bromocriptine, or doing surgery in some cases. And because we know there's such a high risk, that 31% risk that a macroprolactinoma could grow during pregnancy, if we can't adequately shrink them with medications before pregnancy in the preconception period, it may actually be reasonable to do surgery prior to pregnancy. So that would be, for some patients, the right way to optimize them and maximize their safety before they get pregnant.
Well, awesome. Thank you so much, Molly, for taking us through, the workup of hyperprolactinemia and how to go about treating it. What are some takeaway points that you want our listeners to get from this episode?
Yes, major takeaways for the practicing OBGYN. So think about what is your reference range for prolactin, and then when do you order it? Make sure you're catching it as part of all the appropriate workups. And then if you have an elevated prolactin, you want to repeat it. Make sure that you're getting rid of all those potential causes for a false positive, and then really knowing their history and really detailed medication lists to see if any of those causes are there. Thinking about when to get brain MRI, making sure you're ordering that appropriately, make sure you're getting pituitary level slices, and then thinking about how to manage it when they're trying to get pregnant, and then once they're pregnant, see how that management would go. And if you have a patient who is pregnant and has a prolactinoma, really wanting to check in on visual field and making sure they're not having vision changes or headaches during that pregnancy.
Fantastic. Well, Dr. Kornfield, again, REI fellow at OHSU, soon to be assistant professor at OHSU. Thank you again so much for sharing your knowledge with us today. We really appreciate it.
Thank you, guys. I'm so excited to be on a Creogs Over Coffee. I think this is like a life goal complete.
Well, thank you again, Dr. Kornfield, for coming on to our podcast. So I think that brings us to the end of this podcast. And once again, this is Fei.
This is Nick.
And this has been Creogs Over Coffee.
So guys, if you enjoyed the podcast, head over to iTunes, Spotify, Google Play, whatever your podcatcher is, give us a 5-star rating and review.
You can find us on social media on X at CreogsOverCoff1, on Facebook and Instagram at CreogsOverCoffee. And if you want to donate to the show, go ahead and go over to our Patreon at www.patreon.com/CreogsOverCoffee.
You can find show notes for this episode and all of our previous episodes on our website, CreogsOverCoffee.com.
And if you want to reach out to us, have a question about the show, have ideas for an episode or a correction for us, go ahead and email us, CreogsOverCoffee@gmail.com.